Okay. So, Michelle, just a quick thank you prior to your thank you and the many thank yous that are going to come from this seminar by Dr. Dryson. I wanted to thank Evan for his commitment to creating awareness around TBI. I know it's quite topical for people in the AFL world and the soccer world and the football world at the moment to be talking about concussion. The awareness that you are creating with this type of presentation and the discussions that I'm sure will ensue from it are very important. It has implications far beyond smashing your head. I'm not trying to diminish at all having an injury from a motor vehicle accident or in a workers' compensation claim from someone that's been driving a heavy vehicle for a long time in mines or elsewhere. I'm not trying to diminish any of that because that's very serious as well. However, in the space of our athletic world, it's really not getting a lot of attention, and even the language that people are using still don't reflect what is current knowledge, current best practice in your space. Evan, I know you're not a technical expert in the space, and you've said as much to me. It's more the neuro space or the neurological space or the cognitive psych space. However, the way you are able to succinctly pull all this information together from the different specialties and succinctly be able to present in a way that even a layman like myself can understand the catastrophic implications of TBI. I'm very grateful again for this, and just wanted to say that it's appreciated not just by myself, but as I talk amongst my colleagues and friends, it becomes something that I feel like needs to be ongoing and continue to be discussed, to the extent that I'm also involved in the insurance space, and we're looking at how we might be able to construct a workers' compensation policy for athletes who up until now haven't been able to avail themselves of a comprehensive workers' compensation policy on the basis that their employment is defined as entertainment and they don't have access to ongoing treatment post their careers. So there's a policy that was just written literally 2-3 weeks ago in the UK. It's a significant change in how traumatic brain injury is viewed and treated and compensated. And it will hopefully be part of future discussions in Australia as well. And that was in no small part due to the awareness that you created with myself. So I thank you for that, Evan. It's really meaningful. It's got personal implications for me, and I'm hoping to be able to continue those conversations and learn from today. So that's enough from me. Thank you, Michelle. Back to you.
All right. Thank you, everybody, for making time in your day to join us for Evan Dryson, Dr. Evan Dryson, occupational and environmental medicine physician. Evan has been associated with MAG business for some years and is highly regarded in his field. His areas of interest include chemical toxicity, occupational cancers, occupational overuse syndrome, occupational stress, and, of course, traumatic brain injury and mild traumatic brain injury. The last time he gave this similar seminar to this, it was extremely well received, and we've had people saying, please, please do this again. So without further ado, I will hand over to him. What I want to say, though, is if you can remain muted, please, at all times, so that we don't impact on the quality of the recording. If you have questions, please put them into the chat or wait until the end of the presentation to ask them, please. Also, if you have your camera on, may I ask that you ensure that persons in your workplace or home don't come in and take off their clothes, as did happen to us in a previous seminar. Just a hint for players who are not so tech savvy. Anyway, without further ado, Evan, over to you. You just let me know when you want me to click to the next slide.
Okay, so thank you, Michelle, and thank you, Mark, for that introduction. So the title of this presentation is The Effects of Mild TBI on Return to Work. And the reason for this is because, as you've heard, I am an occupational physician, and part of our expertise is assessing people's ability to return either to their original work or to alternative work. Now, traumatic brain injury, of course, is self-explanatory. It means that the brain has been injured by some process, usually by blunt trauma, that is, you've been hit on the head or you have fallen and hit your head on something. But it's important to remember that TBI can also be caused by non-blunt trauma, such as the brain being shaken around in a motor vehicle accident where the head jerks forwards and backwards. This is called coup and contra coup, which means that the brain is impacting on the inside of the skull in a oscillating manner. So explosions can also cause TBI without a direct blow to the head, and that's due to, again, the oscillation of the brain in response to the explosion. And this can be relevant to, say, for example, members of the armed forces or people in the construction industries who are using explosives. Now, traumatic brain injury, TBI, is classified as mild, moderate, or severe. And there are ways of deciding in any one individual as to which category it falls in. And it involves the use of various measures such as the Glasgow Coma Score, which we will bring up the next slide, please. So the Glasgow Coma Score is a measure of unconsciousness, if you like, and it is administered in a sequential manner, and it has three major parts: eye-opening, motor response, and verbal response. And each of them scores numerically, and I've given some examples here. For example, opening eyes to spoken request, or no movement when asked to move, or no verbal response when asked a question. And so the scores are added up and you get the total Glasgow Coma Score. The next instrument is the post-traumatic amnesia, if we could have that slide up.
Sorry, what?
The next slide, please.
Put yourself on mute.
So post-traumatic amnesia, as the name says, means the period of time that someone is unable to remember following a blow to the head. So after the trauma, post-traumatic amnesia is loss of memory. The longer that the loss of memory occurs, the more likely it is that you've had a severe concussion. So the Westmead post-traumatic amnesia score was developed here in Sydney at Westmead Hospital. There are 12 questions, 7 assess the orientation and 5 assess your memory. And so you get a score, and that can be tracked day by day until such time it is concluded that post-traumatic amnesia has resolved. So the next slide, please. So this is the way that we can measure the severity of traumatic brain injury. You'll see on the top row, there's the Glasgow Coma Score, there's the post-traumatic amnesia, and there's the period of loss of consciousness. So a mild traumatic brain injury would, for example, have a relatively high Glasgow Coma Score, post-traumatic amnesia of less than 1 day, and loss of consciousness, which is relatively brief. And you can see from the table that the moderate and the severe are progressively higher scores. Next slide, please. Now, you might think that mild TBI, being mild, is not worth worrying much about. Obviously, it's the moderate and the severe that is going to be more marked in the way of symptoms. But if you did think that, you would be wrong, because there is much evidence that mild TBI can be just as debilitating in terms of its long-term effects as the moderate and severe TBI. Now, the sort of symptoms that you get with mild TBI are listed here. So the somatic symptoms, the body symptoms are, for example, headache, dizziness, intolerance to light, intolerance to noise. The cognitive symptoms are problems with attention and concentration, problems with memory, whether it be long-term or short-term, problems with multitasking, for example. And then there are the affective symptoms, such as irritability, anxiety, and depression. So next slide, please. So mTBI can be classified as uncomplicated, and that means that there's no abnormalities on CT scan. Or it can be complicated, which means that you do have symptoms of concussion, but there are CT abnormalities, which includes hematomas, shift in the midline structures, or even a fracture, although that is more likely to be seen, of course, in a severe TBI. Next slide, please. Now, it is known that some 10 to 20% of mild TBI do not settle. They go on to have problems for a long period of time, and that can be months or even years. So this used to be called post-concussion syndrome. And I point out that not every mTBI patient does develop post-concussion syndrome. This is a name that has now been dropped because it has been recognized that it's a condition which may be largely psychiatric in origin. There are two main classification systems used in the medical world. One is the ICD, that's the International Classification of Diseases, run by the World Health Organization. And they had post-concussion syndrome as a diagnostic entity in the ICD-10, but the recent ICD-11 has dropped this term as a diagnostic entity. The other classification system is the DSM, Diagnostic and Statistical Manual of Mental Diseases, run by the American Psychological Society, and that also had post-concussion syndrome in its DSM-5, but in the more recent one, it has been dropped as a diagnostic entity. So you might say, why is this? And you can tell from the fact that it comes under both the physical and the mental classifications that this condition does span both physical and mental conditions. So much so that it's not clear how much of the symptoms are due to other psychiatric conditions such as post-traumatic stress disorder or not. So if you're going to look up these entities in the ICD-11 and the DSM-6, you'll find them under a neurocognitive disorder, but that is no longer specifically related to concussion. Nevertheless, I think that the concept of post-concussion syndrome is still very relevant, and it is useful to explain what is going on in people who have persisting symptoms. Next slide, please. So this is just to show what you might do if you have persisting symptoms. If you haven't already had a CT scan or an MRI scan of the brain, that you would do it now. Other conditions such as benign paroxysmal positional vertigo, which might be causing dizziness, obstructive sleep apnea, which might be causing the fatigue, and other sleep disorders. Yes, we'll have the next slide, please. So people with post-concussion syndrome do have problems with returning to work. And these include psychosocial factors, which you might think are unrelated to any physical injury. For example, people who are unmarried are more likely to be unemployed at the end of the first year. There's no reason why this should be, but maybe they have more support at home if they are married. People with lower levels of education are more likely to be unemployed. Maybe this is because work for the lower educated people tends to be more manual, and they might have a struggle with that. Manual workers are indeed more likely to be unemployed than non-manual workers. Other factors which contribute to poorer return to work are the loss of income and involvement in litigation where there is a problem with fault. Fortunately, in spite of the fact that a lot of the symptoms are vague and cross over with pre-existing or concurrent mental conditions, there are ways of determining what level of impairment people with post-concussion syndrome do have. And this is the neuropsychological assessment carried out by a neuropsychologist. It involves a test battery which crosses all cognitive domains. In other words, it looks at all areas of cognitive functioning. The neuropsychologist is able to develop a pre-morbid estimate of cognitive function by various techniques such as level of education and so on, so that this gives a baseline in the case of any one individual by which their current cognitive function can be measured. Then the tests go on to look at various domains such as attention, which is the same as concentration, working memory, processing speed, language, visuospatial, which is the ability to see things in 3 dimensions, and executive functions. The executive functions are, to me, very, very important following mTBI, because it means that executive functions means the ability to plan and organize. So this is obviously of considerable relevance to return to work, where people are doing demanding work, which does involve planning and organization. So the neurologist will also look at things like anxiety and depression. This is done by self-administered questionnaires, which comes up with scores, which will tell you whether they are depressed, whether it's mild or whether it's severe. It'll tell you whether there is symptoms of anxiety, whether they are mild or whether they are severe. Now, you might think, how come that this tool is so useful in terms of being a true measure of a person's impairment? And the way that this is done is to carry out tests which are called performance validity tests, and that will show whether the person being tested is malingering or not. So the tests that are operated overlap. So every test that is given doesn't just test one domain, but it will also include portions of other domains, so that you can imagine that if somebody is malingering, pulling the wool over the neuropsychologist's eyes, or trying to make things worse than they really are, they are not capable of doing the same impairment in all different tests where the same function is being tested. It becomes very obvious that the tests are not valid. The tester will also check for what is called effort, and effort testing involves administering tests which are not expected to be abnormal to see whether or not the person does do poorly in such a test. So they're valuable, very valuable indeed. And as an occupational physician, I rely heavily on the neuropsychological assessment because it's going to tell me what parts of the person's functioning can be matched up to the specific tasks that they will be required to do at work. So next slide, please. I just want to mention frontal lobe impairments because they have such a marked effect on people's ability to return to work. As I've already said, the frontal lobe is involved in areas such as planning and organisation. So if the frontal lobe is damaged, and obviously it's the one in the front of the brain, it impairs areas of not just planning and organisation, but it also causes problems with anger, irritability, increased impulsivity, and decreased inhibition. So you can see that if someone is experiencing ongoing frontal lobe dysfunction, they will have big problems with, for example, working with other people in a team because of their short temper and irritability. They will have big problems working in contact with members of the general public because of irritability and impulsivity. They have problems with working in teams generally. So next slide, please. As people recover, and you expect that most people will recover, it is possible to track recovery by doing repeated neuropsychological testing. There are issues to remember though. The more often you test somebody, the more practice they get at giving the results so that the tests can become invalid. So it's generally recognized that it's best to use different tests measuring the same domain to avoid the effects of practice. It's also recommended that you don't repeat the tests too often, and it's probably better to wait for a year before you do the second test. Most post-concussion will resolve within 1 year, and it's only the few unfortunate cases which go on after that which do require repeated neuropsychological testing. So such testing can be the whole battery, formal reevaluation, or you could just select specific tests which you know are sensitive to changes over time. Next slide, please. So here's a list of the sort of behavioural changes that you can experience after mild TBI, and we've already touched on this. So increased frustration, increased anger or aggressiveness, difficulties in self-control, mood swings, lack of social judgment. I'll just share at this time the reason why I did become so interested in mTBI as an occupational physician, and it relates to a whole series of patients that I've seen over the years who have had mTBI, and their lives have become an absolute disaster. Because of their anger and irritability, they have problems at home, they have marriage breakups, their children stop talking to them, they lose their friends, they can't go back to work, and they just spiral downwards. A really tragic situation, and something that must be recognised, because they tend to be blamed. You know, why are you so angry? Can't you control yourself? But it really is the effects of the TBI. Next slide, please. There are some physical problems following TBI, and balance problems are important, particularly for me as an occupational physician, because there are many jobs which require good balance, you know, like working up ladders, working at heights, you know, operating dangerous machinery and so on. So 40 to 60% of cases do experience balance problems after TBI. Some of these are due to dislodgement of the otoliths in the inner ear, what's called positional vertigo, and some are due to concussion of the labyrinthine system itself. Some indeed are due to psychological factors. Next slide, please. So coming back to the return to work after mTBI, I produced the studies last time that I talked about this, but they're worth just repeating again. Mostly people do achieve a return to work after mild TBI, but even those that do get back to work, a considerable percentage, that's 44%, do have ongoing neurocognitive symptoms. And when you ask them, they say, it does affect my work, you know, I don't work as well as I used to, I'm getting less done in the same time, I make more mistakes than I used to. The second study shows that after 4 years, only about 19% had left the workforce, but a considerable number of those had to make workplace changes. They were taking notes more often, whereas they used to rely on their own memory. They are slower than before, they have to take more breaks, they are maybe working part-time. So next slide, please. So we've already touched on these issues. If you're looking at somebody's return to work, and the standard way of doing this as part of occupational medicine is that you match the impairments to the specific tasks of the job that they're going to be doing. So if they are working at heights or climbing ladders or working on scaffolds, and they do have balance disorders, you do not let them go back to work. You'll remember earlier on that I said that one of the common symptoms is intolerance to noise and intolerance to bright lights. So you imagine being asked to return to a noisy office where there's a lot going on around you, where you might be experiencing glare from the windows, or you might be experiencing glares from your monitor, and you're going to struggle to remain at work. Next slide, please. People with impaired memory obviously have problems with work which is of high cognitive demand. People with impaired attention and concentration have the same problems. They can't return to work which requires deadlines. They can't return to work which requires multitasking. Next slide, please. Frontal lobe impairment, as I've already discussed, is a disaster for people who have to maintain a good balance in terms of their affect. In other words, good-humoured, good-mannered, well-mannered, don't get angry, don't get irritable, don't call out people who are not doing what they think they should. So dealing with the public, frontline jobs may be a problem for people with frontal lobe impairment. dealing with fellow workers working in teams may be a problem for people with frontal lobe impairment. Next slide, please. So how do we manage people with mild TBI? Well, in most cases, it's expected that recovery will occur. It has certainly been shown over time that there are some things that you shouldn't do, which makes it worse in terms of recovery. So the important things that you're looking at are headaches, which can be treated with analgesia, insomnia, which can be treated with appropriate measures such as going to bed at the right time, making sure that the room is quiet, making sure that you are maintaining a good balance in terms of your wake-sleep life. Anxiety and depression can be treated by means of behavioural therapy, going to a psychologist, having antidepressants. Keep your life well ordered, don't skip meals, keep hydrated, avoid opiates, which create their own problems, but over-the-counter analgesics is useful for people who have ongoing headaches. Have a regular sleep schedule, avoid stimulating foods and beverages. It's been shown that regular exercise, even as little as 20 minutes, 5 or 6 times per week, is beneficial in recovery from mTBI. And of course, we've mentioned that referral to a psychologist if symptoms persist. Is that the last slide? Yes. So that's my presentation. I'll be very happy to take any questions.
That was really, really lovely. Thank you so much, Dr. Dryson. Absolutely incredible. Let me go back to everybody. We had a lot of people join our talk today, as you can see. People, have you got questions? Okay, there aren't questions in the chat.
Explained it so well.
Look, that is actually what happens. Often when the presentation is so comprehensive, everybody is just like,
questions
answered. They don't have anything to ask.
Evan, can I ask you a question?
Yes.
So just with, in the context of what I've been hearing publicly with rugby league, rugby union, AFL players, what is the how do you see mTBI applying to those types of concussion, and is there any difference in the application of your mTBI diagnosis for those types of concussions?
Look, it's well recognised that contact sports do have a greater share of head injuries than other sports. The effects in terms of mTBI are really just the same. What I would like to point out, and I didn't mention it in my presentation, is that repeated blows to the head are more significant than just one blow to the head. The first blow, you may recover reasonably quickly and not have any ongoing problems. The second blow, you might take longer to recover. You might have ongoing symptoms. And the more often that you get a blow to the head or concussion, the longer it takes to recover and the more likely it is that you'll have ongoing symptoms.
Wow. And I've got some questions in the chat here. One of them says, thank you very much, Doctor. How long could you expect the symptoms for after a repeated head injury?
Yes, well, we've just touched on that. So repeated injury means that the symptoms last longer and longer. So for the first blow to the head, most people recover within a few weeks. The subset that go on and on will generally recover within 1 year. So it's unusual to have ongoing symptoms after about 1 year.
Okay.
The problem
Another
with
question.
repeated injuries is that this time span increases.
Right. There's another question here. It says, what does Dr. Dryson have to say about CTE? We hear a lot about the connection of CTE and repeated blows, especially those seen. Hang on, there we go. Can a single mild, moderate or moderate traumatic brain injury induce progressive neuropathological changes? And if so, what is the latency period?
I'm sorry to say that I can't really answer that. I'm not a neurologist. Yes, it's encephalopathy, which is progressive. I don't personally know the relationship between mTBI and progressive encephalopathy. What a hard word to say.
Yes, it is a hard word. All right, look, that's just great.
One other question, if I may, Michelle, to Evan. Is there any evidence to suggest that the effects of concussion are greater in women than in men?
I think off the top of my head that is correct. I don't have any details with me here.
And recovery?
That I can't say, Mark.
We'll get you researching that one for the next one.
Yeah,
Okay.
yeah, definitely something to find out about, which does have interesting implications, especially with more and more women now very publicly getting involved in contact sports. And of course, women in the Defence Force, for example, only in the last 10 years able to do some of the professional activities that are associated with mTBI down the track. So
yes.
Thank you, everybody, for making time today. Very, very grateful. We look forward to you joining us on our next seminars. We thank you, Dr. Dryson, again for making time available for us again. The recording will be sent out to you guys all within the next day or so. Have a wonderful rest of the day.
Thanks again, Evan.
Thank you.